Welcome everyone to a fun and fantastic Arcana nephropath discussion on NephMadness 2022, the 10th year of NephMadness. Hi, I'm Matt Sparks. I'm a nephrologist at Duke University. I'm a co-creator of NephMadness and part of the executive committee. I'm joined by two of my really good friends and colleagues, Sri Sharma from Arcana Labs. Please introduce yourself.
Hi, Matt. Thanks a lot. Yes, I am Sri Sharma. I'm a kidney pathologist and lab director at Arcana Laboratories.
And we're also joined by Elena Cervantes from Johns Hopkins University. Please introduce yourself.
Thank you, Matt. Hi, everyone. Hi, Sri, as well. And thank you for all your help. My name is Elena. I just finished fellowship and I am a freshly graduate from Hopkins and now faculty. Glad
Fantastic. Well, we are really excited about this matchup and this region of NephMadness. First, I want to talk to you guys a little bit about what NephMadness is. We've been doing this for about 10 years. And as everyone might know, I actually grew up in Arkansas and I grew up right down the street from Arcana Laboratories, okay? And so this is like home to me to have Sri on the program, although he's not necessarily, he didn't grow up in Arkansas, he's now a true Arkansan. And what that means is you have to all root for the same basketball team, the Arkansas Razorbacks. And when I graduated from high school, we won the national championship and we were just in love with college basketball. In March of every year, the entire country just goes wild to follow their team in the NCAA basketball tournament. And this is really fun and exciting because there are always upsets and unpredictable winners. And so when Joel Toff and I were thinking about what we could do to sort of spark some excitement into the field of nephrology, we said, hey, what's better than March Madness, that's what we call it, than NephMadness, where we can talk about some of the new and exciting things happening in the field in a fun and engaging manner. And that was really the impetus to start NephMadness. And so we created this tournament where different teams or concepts in nephrology will be paired up together in an imaginary contest. That contest is determined by votes from the Blue Ribbon Panel, which is a group of preeminent nephrologists and patients and others around the country and the world that vote to see which of those teams has the most potential or to cause a positive impact in the patient's lives in the future. And so that's kind of the premise for it. We did not want to make it an objective measure because we wanted upsets. You know, we did not want the team that was known the best to win. For instance, if Capril was in, everyone knows that, it would always win. It would be like Kentucky or Duke or UNC. And we wanted to have the underdogs, the new advances, the things people hadn't considered before. And so with this year, the 10th year of NephMadness, one of the regions is nephropathology. And I think that there is so much excitement happening in nephropathology. The other thing is there is no other specialty with the tight connection of pathology and a clinical subspecialty like nephrology. There's just nothing else like that. And so I think it's really exciting. And so we have Sri Sharma here, who has graciously agreed to be our expert of this region. And then we have Elena Cervantes, who helped write this region. So let's go ahead and kick this off. Before we get going, Sri, any questions about NephMadness? Because I know this is one of your first sort of ventures into this new territory.
You have explained it in a very nice way, Matt, and thanks a lot for this opportunity. I have enjoyed this journey and I'm looking forward to learn more about it. So I will ask you questions as we move along, but you did a great job.
Great. So let's talk about this. So we have, we divide NephMadness into 8 regions. One of those 8 regions is the nephropathology region. We have 4 teams that represent this region. So I want Elena to tell us just tell us what are the 4 matchups, and then we can dive into each of them.
Yes, absolutely. So in the nephropathology region, we have, well, the famous PLA2R versus the other antigens.
So we got the Goliath PLA2R going up with against all the other antigens. Is that right? So one team is PLA2R, the other one is other antigens in membranous.
That is just right, exactly. And before people, dive into conclusions, we have a very nice, we have very nice information about both of them. And the other team is DNAJB9 versus IgG4 disease. That's the second.
And I'll
team.
tell you, I'm just going to be a spoiler alert. I love DNAJB9. I am in the process of getting my tattoo sort of configured, like where it's going to go near the hagfish or wherever. I think DNAJB9 is a great advance in the field. And I think a lot of people don't give it as much props as they should. So you're going to hear me talk a lot about DNAJB9 because I really think it's a cool advance and something that I know nephropathologists, I feel like it takes a lot of the guesswork out of looking at little microtubules on EM, so that's pretty cool. All right, so 4 good teams, PLA2R up against other antigens, and then we have DNAJB9 versus IgG4 related kidney disease. So let's just go right ahead to the Goliath. PLA2R. Shri, obviously, this has been a perennial favorite, been around for over a decade now. Can you tell us about when this was found and what was the view of the pathology community when this was first, sort of coming out in the literature?
Yeah, sure. So PLA2R, the story started in 2009, right? When Beck and Salant, that paper came out and PLA2R was discovered in membranous. To me, that was the starting point when we started changing the face of kidney pathology because it was discovered as an antigen. We got to know that primary disease is no longer idiopathic. We know how it is associated with it. And gradually what happened, initially it was used as a diagnostic marker. Okay, a subset of primary membranous are PLA2R driven. And then gradually as we moved forward, we started utilizing PLA2R as a therapeutic marker and we started monitoring patient. So it has changed the way we have started interpreting kidney pathology. It has changed the way we manage our patients. And I think that was needed for the field of kidney pathology, because if you look at other branches like cardiology, hematology, they have moved forward a lot and kidney pathology almost was lagging behind. So to me, PLA2R story was very, very important. It was discovered in 2009, but by 14 and 15, people have started using it. We started to know that it has important in therapy, it has important in transplant. And because of that story, we have another team, PLA2R versus the others, like THS D7A came out in 14. And then we started having bunch of other antigens in last 2 years or 3 years. So the phase of membranous has changed and PLA2R started that. And now because of that story, I think similar thing will happen to the other disease branches also, like lupus and many other diseases, like you favor DNAJB9. So I think many other diseases are going to see the change because of what started with PLA2R.
So what advance that changed in 2009 that allowed for this discovery? I mean, when I was a resident, one of my very first presentations that I gave, like you had to, do your, presentation to the group was on membranous. And, we were really struggling with trying to figure it out. Like we had heminephritis and megalin story, but really nothing translated to human models. So what was it that changed? And also maybe you can speak a little bit about like, was it immediately accepted as like, this is it, or was there skepticism?
Takes a while to understand, but PLA2R story was strong. People started adapting it very soon as it came out. But I think one of the major things why so many antigens are coming up recently is the tools. Now we have tools to identify those. So one of the tools, which I will say, is mass spectrometry. So with that, what happens? Suppose if I'm looking at a tissue on a piece of slide, I can exactly cut out the gloms. I can take out the gloms, collect those gloms in a separate receptacle, and I can do mass spectrometry. And I can actually quantify the protein, which protein is dominant, So I think that tool has changed it. That's why in last few years, you are seeing so many antigens which are coming out. And most of them have come out because of mass spectrometry.
That's great. Is it routine for all pathologists to measure PLA2R in the tissue, or is that still not completely routine. I mean, as a nephrologist, we measure it a lot in the serum, but can you speak to that? Is this something that all pathologists do, is measure?
Yes, PLA2R is routine, as well as other antigens. In cases where PLA2R is negative, other antigens is also now standard, because PLA2R, we know how important that is. So we do, like if PLA2R is negative, we will go for other antigens also. But
Great.
I will say most of the pathologists are going to do it routinely.
Well, definitely, this is an exciting area of PLA2R discovery. I think it's definitely a bright spot in the field that really continues to shine. Alina, tell us about, as a nephrologist, like, what's your view on the use of PLA2R in clinical medicine? How often and how do you use it?
Thank you, Matt. Yeah, so PLA2R, we use it widely. I think every time we're approaching a case of nephrotic syndrome, and it makes things much easier. We order like our serologies for patients that come with nephrotic range proteinuria, edema, hypoglycemia. And the big question that has come into place is, well, do we need to do a biopsy or not if the PLA2R comes positive? And I think that has been a field that has been evolving, and now we have like more information to guide us on that end. We have a serology-based approach in those cases where PLA2R is identified. And what I found particularly interesting is that even the titer can help us risk stratify these patients. And in the past, and that's how I also learned about membranous nephropathy, right? Like, oh, we risk stratify patients based on the degree of proteinuria. But I was really glad to see that the 2021 KDIGO guidelines now incorporate the titer into these risk stratification categories. And the other important point there is that the titer is relevant for prognosis, and those patients with higher titers have a higher risk of progression, and it's relevant for transplant, as Sri was explaining. So having these titers to not only diagnose but also risk stratify and guide therapy and the transplant prognosis, I think has made our field very hopeful, having more tools besides all the biopsies.
That's great. So it sounds to me like, how in the world can other antigens even come close? So we have a novel discovery that really paved the way for so many other things in the field of pathology and nephropathology in particular. And then you also have something that can be used to diagnose a disease that's non-invasive. In certain scenarios, it could be challenging. Not everyone you can do a biopsy on safely. So that's an important advance in the field. The other thing that's useful in monitoring therapy, I think, is something that, just having proteinuria sometimes is not, it's good to have other options as well. So the last thing is, I remember when this was first discovered, I thought, everyone sort of had this idea we would have really directed therapies to PLA2R. And I think when I look at it, is this the biggest sort of issue with PLA2R that's been now 12 years? Are we on the cusp of finding a directed therapy to the actual antigen?
Well, I think that's where the hopes are, right? Moving towards targeted therapies. And a nice point that you mentioned, Matt, is about, we used to classify membranous nephropathy as primary and secondary, and PLA2R happened to be the most prevalent antigen in up to 80% of the cases of primary membranous nephropathy, but it was identified in 60% of all membranous nephropathy. And now we have, as we're going to talk about the others, we have all these other antigens that kind of start challenging this concept of primary versus secondary. From what I'm aware, we are still not at the point of having those targeted therapies, but being able to identify the antigens is definitely a huge important step there.
Great. Okay, so let's go ahead and move on to the other antigens. And this really is multiplying rapidly. And I would love to just have Shri kick off this. PLA2R seems pretty powerful, but there's a lot of other antigens. So maybe the cumulative effect of them can really push this forward. So Shri, what are the other antigens and what's on the horizon and how are we going to start using this?
Yeah, definitely. So after PLA2R, the next one which came was THSD7A. So initially when it came, we thought it's going to be very similar to PLA2R. Then a couple of case reports came and they said that a fraction of the patients who have THSD7A associated membranous, they can have underlying malignancy also. And there were some case reports which ended up showing that the malignancy is present and the antigen is expressed by the malignancy. But again, some other reports came out and that showed that percentage of malignancy is not a lot. So basically with THSD7A, it is similar to PLA2R because we can have the titers in the serum, we can follow up, but there are a subset of patients which are going to have underlying malignancy with THSD7A. Similarly with NEL1, which was the other which came out, NEL1 also a subset of patients who have NEL1, they can have underlying malignancy also. And from the pathology point of view, before this antigen story started, we were seeing a subset of membranous where the staining of IgG was not complete. It was all an incomplete pattern. And sometimes we used to wonder, is there an entity known as segmental membranous? So NEL1 is basically staining that category where the staining of IgG is not complete. And when you see NEL1, a subset of your patients are going to have malignancy. That is where the similarity is there between NEL1 and THSD7A. And there are some other antigens which came out, like semaphorin 3B. It is more common in kids. And then we ended up like realizing that the way we visualize membranous as primary and secondary is not right. And why was that? Because some more antigens came out, like EXT1 and EXT2. And that was expressed in patients with autoimmune diseases. So basically, we started understanding membranous is a pattern, and there are going to be a bunch of antigens which are going to be positive in that. So what will happen if we see that going forward in next few years? We will have PLA2R associated membranous, THSD7A, NEL1, EXT2, and bunch of other antigens which will come out. We will see how those patients are going to behave different clinically, how they are going to respond different therapeutically. Right now, the numbers are so small, we don't know that outcome-wise and therapy-wise as well as transplant-wise. But I think going forward, each category might end up becoming a separate disease. Like right now, we think everything is a membranous, but it is possible that each antigen might end up behaving and getting treated in a different way as we move more towards precision medicine. And this concept, you can imagine, you can apply in lupus also. Because right now we think lupus as one disease, lupus membranous as one disease. So now we know there are a bunch of antigens even within the lupus membranous category. So we will be able to subdivide. So I think with this multiple antigens which has come out, we can see multiple subcategories within the main category. And hopefully this will translate into better treatment, better patient outcome, and basically better outcome for the entire patient community. Yeah.
Well, wow. Now I'm sort of thinking that PLA2R is not going to have a chance. So that's really interesting. So, if you look at our scouting report, there is a figure from the AJKD nephropathology core curriculum, and it's a pie chart, so let's just take a look at that pie chart. I think that's really important to see. That pie chart is sort of fills in all the antigens. And the thing that strikes me most about it is like, we've almost filled the pie up with antigens. I mean, we are 75% of the way of describing almost every single membranous disease with different antigens. So the first thing to recognize is PLA2R is by far the most common with 60%, 50 to 60%. And then after that, THSD7A is actually, it's a small little sliver, but then you add SEMA3B, NEL1, EXT1 and 2, that's another 25%, all of these. And so that's really exciting to see that. Now, the question is, are we there yet? Are pathologists using, these?
Yeah, we use that in routine practice. Like if suppose I start with PLA2R, if PLA2R is negative, then I will start doing other antigens. Then I will do THSD7A. If the pattern of staining is incomplete on my immunofluorescence, I will go ahead and do an L1 also.
Okay, hold on a second there. When you say incomplete, are you saying that when you look at the glomerulus and you stain, it's patchy? Is that what you mean by incomplete?
By incomplete, I mean when you look at a single glomerulus, rather than the entire tuft of the glomeruli, only few of the tufts are going to be positive for IgG. That we call as incomplete global staining for NEL1. You will have patches of the glomerular capillary loop which are not going to stain. So that is how we predict that most likely this will be NEL1.
Of the glomerular capillary loop don't stain, and that kind of, so you look at that and you say, hey, this is, might be NEL1. This is like just staining with IgG.
Yes. And yeah, so that is how we predict, okay, it might be NEL1. So then we do NEL1. And if we are suspecting something autoimmune, we will go ahead and do EXT1 or EXT2. And when that is positive, we are more inclined towards autoimmune etiology,
Now, just tell me, is EXT1 and 2 always associated with lupus, or can you see that outside the context? Does that even happen?
Most of the time, it is associated with lupus or autoimmune disease.
Other autoimmune disease.
Other autoimmune disease.
Outside of that, you don't really see it at all.
Yeah.
Got it.
And at currently, we are not using other antigens routinely, like semaphore in 3B, because the subset was small, as well as TGF beta, again, which is positive in lupus. And those patients, a subset of those patients who are positive for TGF beta, neuropsychiatric symptoms are more common in that subgroup. So all those are very small subset of patients. So if you ask me what is routinely used most commonly, I will say PLA2R, THS, NEL1, and EXT are used more commonly because number of patients are relatively more in that subgroup. Others are still less,
Okay.
And gradually it will become more and more difficult because, as you said, most of the antigens we have described, the other subset is a small one. So yield is going to decrease as we move forward.
Let's move and talk to Elena about, how does a nephrologist think about the others category, and are we still sort of wading through the waters, or how do we use this in our practice?
Yeah, I think that so we don't have the ability to check serum levels of all these antigens. I think it's important to mention that some of them have that capability, but I think that institutions are also moving forward to developing that or incorporating that. Currently, in my institution, we are able to identify the PLA2R antibodies, but not the rest yet. And when we have a case of membranous nephropathy, we can also do tissue staining for PLA2R. But then, as Sri was saying, if PLA2R antigen is negative, we sometimes have this conversation and send the tissue to actually Arcana to have them stained for the thrombospondin 7 mainly, and I think also NEL1 or exostosin 1. That's how kind of we have been working through these. I don't know if other places are sending for the other or the newer antigens like the protocadherin and the NCAM. I don't know how frequently used are those, but that's how.
Hold on a second. I just heard two new words. What were those again? You said NCAM and what else?
The protocadherin.
And so these are bench players for the team? Are they like kind of the, like we can send them in if we need them? Is that, tell us about those, because I don't think Sri mentioned those.
I think these ones are actually super new.
Super
new. Protocadherin 7, you can correct me if I'm wrong, Sri, but protocadherin 7 came to play in 2021. So they are like freshly out of the oven. And the other one that I wanted to bring up is also contacting 1. I heard about that one actually during one of the grand rounds that they were talking about the correlation of inflammatory neuropathies in patients with membranous nephropathy. And I was like, oh, this is the first time I'm hearing about that. So these neuroantigens keep coming, and that's pretty exciting. But I don't know, Sri, if you can share a little bit more about kind of the breakthrough of the rookie antigens.
Oh, she's right. NCAM1. So yes, there are multiple ones like NCAM and TGF beta 1. They kind of go together. I ended up saying like a subset of TGF beta are going to have neuropsychiatric. That was not right. NCAM1 has neuropsychiatric. So NCAM1 and TGF beta are secondary. Protocadrine also in subset of patients had secondary, like autoimmune diseases. But we have to keep something for surprise. Otherwise, people are not going to read, Matt, what we are going to put out.
Oh,
And maybe in next 1 month, few more antigens will come up though.
That's right. I mean, that's why this team's expanding. I guess PLA2R is so strong. So, this is really exciting. Membranous is a great area of research and investigation. I still don't really understand why we're getting antibodies to all these antigens. And I think we still are trying to figure that part out. But it's wonderful that now we're starting to figure this out and hopefully have target therapy. So let's go ahead and vote here. Which one do you like better? And I'll start with Shri, PLA2R or the other antigens?
It's a difficult question for me as a pathologist, right? Because for me, both categories are important. If I cannot make a diagnosis, you're not going to treat. So I will let the audience choose. For me, both are important.
Shri, you have to choose. This is part of NephMadness. There's no other option. Which one is it?
So I will choose the other team because see, PLA2R is done. Many people are voting for it. It will move forward. So I'll vote for the other category because a lot of work needs to be done for the other category.
The underdog is your, okay, great. So Elena, what are you going to say? PLA2R, the Goliath, or what are you going to go with?
I'm with Shri. I'm with the underdog. And I just want to say that the newer antigens really came to challenge the nomenclature and what we know is no longer primary versus secondary. It's just really more knowledge about the different pathophysiologies and hoping that we can get targeted therapy. So that's why I'm going with the underdog.
Okay. Well, I'm going to go with PLA2R. I mean, this is amazing story. The others are, I think, interesting for sure, but they're nowhere near as developed. And we have an entire encyclopedia for PLA2R of information about how to use it. We just have small pamphlets for the others. So they need to go and work out and get better. And so I'm going to go for PLA2R in this matchup. That's okay because we're getting ready to move on to the area which I'm actually most excited about, and that's DNA JB9 versus IgG4. So let's go ahead and move to Shri again as a pathologist and talk about DNA JB9. And maybe this is something a lot of people who are listening might not have heard of much. Tell us about the discovery, when it occurred, and what it means as a pathologist to have this in your arsenal.
Yeah. So DNA JB9 is a specific immunohistochemical marker for fibrillary glomerulonephritis. So basically what it means that this is a marker which was again identified through mass spec. We did mass spec, we identified that protein is predominant, we developed antibodies, and that is how we detect. So immunohistochemistry is very commonly available in a pathology lab because we do that routinely for our cases. So what it did, there are many parts of the world where EM is not routine. People, they don't do EM, they make a diagnosis on light and IF. And what DNA JB9 has done, it has given you a specific tool where you can make a diagnosis of fibrillary just by one more antigen or one more antibody test, and you are done. So now you don't have to struggle and do EM on those cases. And suppose if you have a case where the biopsy is not great, we don't have to shoot for EM, you can make a diagnosis just by looking at IF as well as light microscopy. And it is a specific marker, like DNA JB9 is practically positive in almost all the cases of fibrillary, with exceptions of that, like in the series which came out, there were 2 cases which didn't stain, where only heavy chain was present. But otherwise, DNA JB9 is very good stain. It will pick up fibrillary. And in practical life, you will get some cases of fibrillary where you can see congophilia. Traditionally, when you see something as congophilic, whenever there is a congruent positive, you think about amyloid. But DNA JB9 is going to help you to make even that diagnosis. So I think it has improved the life of a pathologist so that they can make a diagnosis of fibrillary much more easier, and it is going to give us a specific marker. So it's good win-win for both clinicians as well as pathologists, because you are going to get a good and specific diagnosis.
So let's just go back just a little bit. So just like, what is DNA JB9 and like what cells express it? And then I just want to make clear though, you're not making autoantibodies like we are in PLA2R. This is just actually DNA JB9 is increased in the tissue. Is that, explain that to our listeners so that we get that right.
Yeah, you are absolutely right. We don't have antibodies or the circulating markers for DNA JB9 yet. So DNA JB9 is a homolog subfamily B member 9. It's a member of molecular chaperone gene family 9. So it is present in the mesangium. We don't know what exactly how it is producing pathogenesis. Is it like the driver of the disease, or is it like present as an epiphenomena? We don't know that exactly how it is driving the disease. Right now, it is associated with the disease. That is what we can say. And like PLA2R, right now, we don't have any antibodies against DNA JB9. So there is nothing in the serum which you can detect for DNA JB9. So basically right now, it is a diagnostic marker, you can say, that whenever you will have fibrillary, you will do DNA JB9 and it will be positive.
Okay. Before we get to the clinical correlation part, I want to ask another question about DNA JB9. So I had heard in the literature, and so I guess this is where like the pathologist really, you really rely on them, obviously, like to really make the diagnosis. There are some examples of Congo red positivity in fibrillary. You mean you talk about that a little bit, and like that to me sounds like that's where this really comes in really handy. As a nephrologist, you think of Congo red amyloid, done.
Yeah.
Is that true or not?
No, you are absolutely right. So our traditional understanding is that if Congo red is positive, we are dealing with amyloid. But there are some cases of fibrillary which can stand for Congo red. So in that cases, we were really going to struggle. How am I going to make a diagnosis in this case? Because Congo red, classically, we know it's amyloid. So in those cases, DNA JB9 is going to help you out. So you do DNA JB9. If it is a fibrillary, DNA JB9 should be positive. And if you are really struggling to make, like only rare cases, you are really going to struggle. I'm not sure what's doing. If the DNA JB9 stain didn't work, you didn't have enough tissue, you can do a mass spec also, because mass spec is going to help you out to make it will differentiate between fibrillary as well as amyloid.
NephSim has a great graphic. And, when I was studying for my board recertification, I was like, man, these fibrils are coming back to haunt me again. This was a few years ago. And so Samira Farouk, she said, I'll make you an infographic. And so I could print that thing off and put it next to my bedstand. Is that necessary anymore to know the size of the fibrils? Is that something that we should be teaching fellows? Or is that now an outdated practice and we can just do the stains, Congo red, DNA JB9, and some of those big ones are obviously, the immunotactoid and such. What do you think about that?
Practical life, size is not that important. You will be able to make a diagnosis. Like amyloid fibrils are the morphology of amyloid and fibrillary is very different when you look at the EM. So when we look at an EM, most of the time, just by morphology, we can distinguish that. But amyloid and fibrillary, I can understand sometimes people can confuse. So DNA JB9 can help you sort it out. So you no longer need to measure those fibrils. Immunotactoid morphology is totally different. The fibrils morphology is different. The size is huge. So you're not going to confuse immunotactoid with that category. So yes, you can say that you no longer need to measure fibrils.
10 nanometers, right in between amyloid and fibrillary.
Yeah. Mm-hmm.
Okay, let's talk, Alina. I want to know about what your view of DNA JB9. When's the first time you heard about this? And you sort of grew up as a fellow when this paper was first published in 2017. So maybe you had just started fellowship at that point. So tell us about your view of DNA JB9 and how it's used.
Yeah, well, DNA JB9, I learned about it during fellowship, evidently, and it is about, we have DNA JB9 positivity. This means we're dealing with fibrillary GN. And the problem is that even though it identifies the disease, we know we're in a very tough spot once we have patients with fibrillary GN. It is a rare condition. And actually, it carries sort of like a bad prognosis in a way, because a lot of patients with fibrillary progress to end-stage kidney disease, like within 4 years of the diagnosis, like 44% of these patients going to dialysis within 4 years of diagnosis. On top of that, the risk of recurrence after transplantation is decent, is around 36%, again, in smaller reports. And one of the questions that also comes once we have a positive DNA JB9 in biopsy is this idiopathic? Is this just fibrillary, to say so, or is this coming because of another associated condition? And among those conditions, the ones that we think about are, we have to look for malignancies, we have to look for paraproteinemias, and even autoimmune conditions. So we identify fibrillary. We know it's not great news. And the question is also, how do we treat them, right? How do we treat this group of patients? And that is also an area that we may not find a lot of guidance. I see you smiling, Matthew. You want to share something?
I think this is why it's such an important discovery. Because, yeah, you're right. It is the most frustrating diagnosis. And I think before we had DDA-JB9, it was a lot of still head scratching. Now, I think it's becoming a little more crystal clear about like what's happening in the pathology. We're starting to understand that a little bit more. And I think it's going to usher a new era in understanding fibrillary. And as you mentioned, fibrillary, just like many pathologic diseases, is it's not just one entity. It's caused by multiple different things. Often it's secondary. But I'm hopeful that the advent of things like DNA JB9 can really help provide some direction into advancing clinical research in this area. So that's what I'll say about it. And if you look at the criteria for the blue ribbon panel, it's about the future. It's not necessarily about now. And the future is very bright for DNA JB9. 2017 was a very initial publication of it. So that's how I would say, and I totally agree, it's frustrating. But the frustration is starting to clear. It's like 2009 for PLA2R, 2017 to DNA JB9. So that's what I'll say about it.
No, I agree. I mean, another thing, we know we're talking a lot about amyloid and how there are certain cases of fibrillary that are Congo red positive, but I want to go to one of our more common diseases like diabetes. And you can probably speak on these three, but there are cases of diabetes that can have fibrils, and these are like diabetic fibrillosis. And it's interesting because, at least that's what I learned while I was writing these section, that, oh Lord, I mean, we may be misdiagnosing a lot of people if it were not because of DNA JB9. High sensitivity, high specificity, both of them nearing, well, sensitivity 97.6%, specificity of 99%. That sounds like it's like the perfect test.
Mean, this is that's why DNA JB9 is getting, yeah, I think you like DNA JB9. I'm hearing it now. I love 100%.
That.
Well, so tell us, Sri, what's the context of doing this? Do you wait for EM to come back, or do you see some of that? Do you look for, like, what point in your algorithm do you say, hey, let's pull out the DNA JB9 stain?
We order DNA JB9 immediately after the IF. So when we start our day by looking at immunofluorescence. So fibrillary has a very classical IF pattern. On IgG, it's going to have a smudgy pattern, like, it will look like a smudge. So as soon as we see that, we request DNA JB9 staining because we know it is a fibrillary. So we don't wait for the EM to look at it and then make that. And as Alina mentioned, diabetes is an interesting scenario because diabetic fibrillosis will be there. But on IF, you will be able to see IgG positivity if there is a fibrillary associated with diabetes. But diabetes can have some background staining for IgG because there is an accentuation, non-specific accentuation in diabetics. So some cases are really confusing. And in those cases, DNA JB9 has really helped out because now you can make a subtle fibrillary because it is possible for a case that it is going to have fibrillary deposits only focally, not widespread, So you are not going to miss subtle cases. You are going to pick it up if you do DNA JB9.
I mean, that sensitivity and specificity is unheard of. Is that real, Sri?
Yeah, that's real. So yeah, DNA JB9 is doing great in life. So yes, it is a savior. If
So
we are
basically, when it
suspecting
goes to the
fibrillary,
free throw line, it's not missing. I mean, bam, bam, bam. So if you're going
yeah,
to close out a game, DNA JB9 is who I would pick. It's like this. It's like Steph Curry of NephMadness. It's not going to dunk, but it's going to make all of its shots. All right. Well, fantastic. Any more last comments on DNA JB9? I feel like we have given it a perfect platform to go up against IgG4. Any thoughts on that, Alina, Shri?
we are moving forward and we are moving away from morphological diagnosis. So this is a good thing we are doing because kidney is mostly based on morphological diagnosis. So all these new antigens are helping forward and we are going away and moving away from morphological diagnosis. So that is one thing I think is really good.
All right, let's move on to IgG4. So IgG4 related diseases is a collection of diseases that can affect multiple organs. And I want to flip this time and start with Alina and then move to Shri. Alina, tell us about this disease and what is it?
IgG4. All right. So we in the section call it a true chameleon because of its multi-system involvement. I think routinely we tend to associate IgG4 with pancreas involvement because that was the first organ described. But truly, it can affect biliary tract, lacrimal and salivary glands, lymph nodes, lungs, and definitely our beloved kidneys. That's what we are talking about it. And IgG4 related disease actually has several kidney manifestations. I think that one of those that we may be more familiar with is the presence of hydronephrosis when there is a retroperitoneal fibrosis. But one of the questions that also comes into play is, do we have to biopsy patients with our retroperitoneal fibrosis or not, right, to make the diagnosis? And probably we're going to see more about it, but I also learned that IgG4 related disease not only presents with hydronephrosis, but also with tubulointerstitial nephritis. That is actually the most frequent finding. And actually, Shri published a paper on this, so he will enlighten us with that. But also there is a group of patients that can present with renal masses. So whenever they do a nephrectomy, because of these renal masses that are suspected to be renal cell carcinoma, they are like, oh, well, it seems that it was IgG4 related disease. So it's really interesting to me to find like these different presentations of IgG4. I think that is, the interesting part of IgG4 is also focus on the serologies that we find that can be quite confusing when we are working up patients with elevated creatinine and if we don't have an overt hydronephrosis, right, that we're dealing with. And we can talk about that in a few, but I want to hear also Shri's perspective on IgG4.
Yeah, IgG4. In 2013, I don't expect everyone to know this. This is for the real NCAA tournament junkie like myself. 2013, there's a team that was called Florida Gulf Coast University, and they were called Dunk City. Okay, they were so much fun to watch. They were dunk. No one's heard of them before, but man. And this is how I kind of think of IgG4. First off, unlike fibrillary, when you have IgG4 diagnosed, I see that is a really good thing because they really respond well to therapy and oftentimes just prednisone. And that's a very unique thing that you don't see very often in nephrology. The other thing is, man, its association in other organs is very interesting. So pancreatitis is something to think about in that case. Maybe someone who's had idiopathic pancreatitis in the past, that's someone that you want to, and now has a acute kidney injury for some reason, or even chronic kidney disease. Like think about IgG4. So let's go to Shri. When do you stain for IgG4? Do you stain everyone now? There's also this plasma cell rich infiltrate that you see. Like, what's up with that? Tell us about IgG4 from the viewpoint of the pathologist.
So clinically, IgG4 is a multi-system disease. Like almost every organ can get involved with IgG4. So when we are looking at a biopsy, when we start looking at the immunofluorescence, in cases of IgG4 associated tubular interstitial nephritis, we see TBM deposits. So when I will look at my immunofluorescence, I will see TBM deposits.
Hold on a second. What is a TBM deposit? Like, we need to describe that for
Tubular
non-pathology.
basement membrane, like the tubules.
Tubular basement membrane, Sri, why do we care? We're all glom people.
So gloms can have segmental membranous in cases of IgG4.
Okay.
But it is not always true. A subset of cases of IgG4 associated tubular interstitial nephritis will have segmental membranous, and other subset is not going to have it. In those cases, you are going to see TBM deposits. So
tubular, so let me get this straight. So you got deposits that are IgG4 positive?
Not IgG4, because we don't do subclasses initially. We are doing our routine stains. Okay. So TBMs or tubular basement membrane are going to be positive for IgG.
Okay, so just doing IgG and that IgG gets all subclasses?
We don't do generally subclasses. Most likely,
I'm just saying like the general IgG stain hits them all.
Yes, hits them all.
Okay, that's what.
So that is how you will pick it up on your routine stains.
You'll stain that, and you're always like kind of going for the gloms because that's what we're mostly interested in. I mean, sorry, tubular people, but you know. But then as you sweep the camera by or the microscope, you see the tubulars lighting up, and you're like, "What the world? This is not supposed to be lighting up." Is that kind of what's happening here?
And you will see expansion because even if it is a dark field, you will be able to see the expansion of the interstitium by inflammatory cells. Like even in the dark field, you can make out that interstitium is expanded by something, you know, because it is expanded by something.
So like basically other cells have come in to call that home. Is that what it is? Okay. So we've got invaders, other cells, inflammatory cells. And then you also have staining from IgG. We don't know the subtype yet, but in the tubule. So that in your mind as pathologist is like, I need to do subtype staining at this point.
Not yet. Because as a pathologist, I'm thinking that, okay, I'm dealing with an interstitial nephritis. It is staining for TBM, and I have my algorithm going on. So most commonly, you will see TBM deposits associated with autoimmune diseases.
Okay.
You know, like in lupus is a very common example. But in this case of IgG4 associated tubular interstitial nephritis, the glomeruli are not going to stain like they stain in lupus. You know,
so
like
gloms will be positive in lupus. IgG4 gloms are spared.
Yeah. And in IgG4, if you see glomerular involvement, normally it will be segmental membranous. Then you will go to your light.
I just want to make clear, you keep on saying membranous. Am I hearing that right? Like,
yeah. Segmental membranous can be seen with IgG4.
Got it.
Because membranous, we discussed antigens, right? But there are multiple other scenarios where you can see membranous. Our conversation of membranous was not done.
I'm going to bring up some of our first fight. Can those antigens make its way into IgG4?
So when you go to the light microscopy, you will see a lot of interstitial in plasma cells. You will see infiltrate that will have lymphoid cells, that will have histiocytes, it will have eosinophils also, but the plasma cells are going to be predominant. And depending on the pattern of the disease, like if you're looking at a plasma like IgG4 in a very initial stage, or depending on the pattern, sometimes the inflammatory infiltrate is predominant. The classical book picture board exam is always going to talk about fibrosis. That happens as the disease progresses. Fibrosis is going to develop and inflammation will become less and less. In a nephrectomy specimen, when they analyzed this disease entity, they saw that the center of that infiltrate was more fibrous, and as they moved away from the center, it was more cellular or more inflammatory. So when we start seeing a lot of plasma cells on the light microscopy, at that point, we do IgG4 staining. We don't have to do all the subclasses. We do IgG4 staining because we would like to count the plasma cells which are present, how many of them are IgG4 positive. So when we do the staining, a subset of plasma cells are going to stain for IgG4. If the number of plasma cells are more than 10 per high power field, we start thinking about IgG4 tubular interstitial nephritis. On pathology, we make that diagnosis because I have TBM deposits on immunofluorescence, I have more interstitial plasma cells, and those plasma cells are staining for IgG4, and the number is more than 10 per high power field. So that is my criteria on pathology to make that diagnosis. But you as a clinician, now you are going to go back and you will correlate that pathology finding with the imaging. Because in the imaging, as Alina mentioned, you might end up seeing a mass lesion, you might end up seeing as a diffuse patchy involvement, but you will see the abnormality in the imaging. And then you will do serology, which will show you elevated IgG4 levels. And then you will rule out involvement of the other organs. Then you will make your diagnosis, because, and the good thing about IgG4 is that, as you said, it responds to steroids. Even if I say the fibrosis is severe on the kidney biopsy, you are going to go ahead and treat your patient with steroids, because the fibrosis can be very patchy, because as Alina said, it can be a mass lesion. So most likely the portion of the kidney from where the biopsy was taken, that portion is showing us a lot of fibrosis, but the other part is not involved. So that's why your patients respond so well to steroids. So that's why it is worthwhile to treat these patients, even on the biopsy, if it reads as severe fibrosis.
Got it. Okay. So just to summarize in a nephrology way, so we take the biopsy, do the PAS stain, light microscopy. Probably at that point, you're going to see infiltration into the interstitium with immune cells, various types. You'll see predominantly plasma cells, which is a clue. You move on to do your immunofluorescence. You'll see IgG staining primarily in the tubules. Can be in the glom, but it's not as common. If it does, it's segmental. When you see those IgG4, you want to do a subclass of IgG4 to see if those plasma cells in the tubules sort of light up, and you'll see that tubular pattern also. And so that gives you the clue. One question about this, is the same pattern of staining occur in other organs? Is that very similar pathology, or it's just unique to the kidney?
You will see interstitial plasma cells in any organ which you will see the involvement. There will be more plasma cells which are IgG4 positive. Yeah.
Okay. Okay, great. This is a really interesting disease process, very important to know. Can you give us any pitfalls to this? Like, do you accidentally miss it, or is it something that as a pathologist, you're always like, hey, like, make sure you don't miss IgG4? Anything you can sort of tell us about that?
So simply positive IgG4 positive plasma cells is not going to make this diagnostic entity. So that's why those criteria are important. A common pitfall in practical life, ANCA associated GN can have increased IgG4 positive plasma cells. So that's why, like, whenever you make this diagnostic entity, go over the criteria, correlate clinically, and then make that diagnosis.
So would it be important to ensure that you don't have ANCA positivity if you have a patient that gets IgG4? Is that a take-home pearl for our listeners?
Or crescents on the biopsy, right? Because you should not have red cell cast, you should not have crescents on the biopsy, and make sure you rule out is it a part of other autoimmune disease? Like, you have to rule out other autoimmune disease. Do your serology. Basically, do the routine nephrology workup before you make this diagnosis. Yeah.
Great. Well, let's go ahead and get to the picks. Anything else you want to say about IgG4, and then give us your pick between the two, DNA JB9 versus IgG4.
So one thing I will say, that morphology of IgG4 is highly variable. So your suspicion should be high as a pathologist to suspect and make a diagnosis. And it is a good diagnosis from the clinical perspective, because patients respond very well to treatment. So it's worthwhile to make that diagnosis and not to miss it. And my pick will be DNA JB9 this time. You know what I mean? Because that has added so much specificity. And that has just improved clinical care a lot. So I will pick DNA JB9 this time.
Great. Okay. So Shree's DNA JB9, he's going to make a pick this time without having to twist his arm. Elena, tell us about what your thoughts are in this matchup.
All right. The only things that I wanted to add about IgG4, since I share the sensitivity and specificity of DNA JB9, well, it's 100% sensitivity and 92% specificity. So it's also a great one. But yeah.
Well, everything they shoot is a dunk. So, I mean, you're not going to miss many of those. So
that's right.
Okay.
But yeah, something that Shree mentioned that also caught my attention as I was working on these, in this section was that IgG4 can stain positive for lupus, for membranous, and even for diabetic nephropathy. So that's why the clinical correlation matters. And another really interesting point is like when we are ordering serologies, make sure that you know these type of things. ANA can be positive in 1/3 of the patients. They can have hypocomplementemia in more than half of the patients. And I think those are big things to keep in mind. And IgG4 levels are not always high. They are high in 74% of the cases. So most of patients have
Should
high
we be
IgG4.
measuring IgG4 levels?
Well, I would measure them. I think they are helpful, and also for monitoring if our patients have IgG4 related disease and we treat them with the steroids, we can probably monitor.
But if you
levels.
already getting a kidney biopsy, does it add much to have IgG4 levels? Just curious. Shri, any thoughts on that?
Alina said perfectly, like, yes, you can monitor the disease. So before you start treatment, if you end up monitoring or ended up taking the titer, you started steroids, it should go down. You know your patient is responding. You don't have to do a biopsy because your kidney function will improve. Your titers will go down. You know your patient is responding to the treatment.
So it's a great prognostic.
Yes.
That baseline could be important. Great. Okay. I'm confused on what you're going to pick.
I know. I'm confused too. But I will go for DNA JB9 as well. And the reason behind that is, even though, yes, I shared all my frustration about diagnosing fibrillary, it just, as I said, just being able to identify that and not be confused about amyloid or diabetes or, those particular conditions, I think it brings a lot to the field. So I go with DNA JB9, always choosing those underdogs there.
Well, no surprise here. DNA JB9 for the win. I'm really excited about this discovery, and I think it's going to be very useful in the future and to help out patients. And the worst thing in the world, I have a frustrating diagnosis, and I want to not have any more of those in the future. That's our goal, is to be able to look at a patient and say, here's what you have, and we got a treatment, like we're going to fix this. Okay, so we got the matchup here. Shri, we got to talk about the winner of the nephropath section. And you went with DNA JB9 versus other. Which one wins between other antigens and membranous and DNA JB9?
Yeah, that is a tough one, Matt. Yeah.
Pathologists never want to completely commit to anything.
No, come on. Because both fields are important. If I don't commit to both, how am I going to take them forward, right? So let's choose others in membranous.
Commit.
Others.
Okay, you're going to go with others. Okay, mm-hmm. All right. Well, you're hedging your bet because that's a lot of different things. I know you. Alina, you have the same two in your finals for the nephropath region, other antigens and membranous versus DNA JB9. What are you going to go for?
I'm going by which disease is more common, and that's why I'm also going for other antigens. Yeah.
Did y'all collude here? Did y'all do this on purpose? Well, it's no surprise for me. DNA JB9 wins against PLA2R. I think PLA2R, it's had a huge impact, and we're just seeing the beginning of DNA JB9, and I want to see more light being shed. All nephrology fellows need to have this right on the tip of their tongue, and also trainees need to understand and learn what this means. So I'm going to go with DNA JB9. Okay, well, fantastic discussion. I want everyone to head over to NephMadness.com, put in your bracket, go to ajkdblog.org, and you can read all about the different teams, go on Twitter and debate, discuss in the hallways of your institution. Or even at home. This is going to be a fun month. March is National Kidney Month. We have World Kidney Day coming up as well. So this is a time that we need to spread the word about all these amazing advances. And I also want to give a personal plug and thank all of our nephropathologists that for whatever reason, nephrologists love to do biopsies on Friday afternoons. And we thank you for taking the time out on the weekend to read those. So Shri, Alina, last comments, and we will see you on social media and Neph Twitter.
Thanks a lot, Matt. It was wonderful discussion, but I'm also looking forward for the discussion online because we were not able to discuss all the nuances and the subtleties. So I'm looking forward for that. So let's start the discussion online.
Thank you, Shri and Matt. I also learned a lot. Tim as well, but he was not able to join us. And I also share that deep gratitude to our pathologists, because without them, we would be in a very tough spot. So that's all.
I want to add one thing. Pathologists are not going to be able to make a diagnosis without nephrologists. So I think kidney, as Matt said initially, it's a clinical pathological correlation, because you cannot make a diagnosis just on pathology. You have to always correlate. So I think this field, we are very fortunate that we get a chance to work together and treat our patients together. So yes, I consider myself as very fortunate to be a kidney pathologist, because I get to learn from a nephrologist every day, because they will ask me questions. Hey, can it be this? Can it be that? So it helps me grow every day, because it's impossible to learn without a nephrologist, because they see the patients, they help you ask questions. So, and right questions are very important to learn anything. So I'm very thankful for all the nephrologists and the patients which help us.
Fantastic. Well, thanks everyone. We'll try to get the outro music from Lion King. Can you feel the love? I think that's what I'm feeling. Good night. Good day. Enjoy. Bye.